Hello, everybody. Welcome to this LinkedIn Live, where I'll be talking to Karen Parker. She's an author, an expert within nasal breathing, and there's a lot to be learned in terms of nasal breathing. I personally have seen significant changes in my productivity, consistency since having some changes to this, and I think a lot of people can benefit from this. I really wish I had the help from somebody like Karen earlier in my journey because literally there's so little good information out there in terms of nasal health. So welcome to the stage, Karen. Great to see you.
Good morning, Matt, and thank you so much for having me. Good morning to everyone across the globe, wherever you may be.
So I guess two quick questions. One, it'd be great to know like what got you so interested in this area, and I also hear you got a book coming out. Just I don't know if it's hot off the press yet.
I do. Yes. So this has been a long journey, and dare I say, and don't do the math, but this whole journey in healthcare has been 33 trips around the sun. It goes back to 1991, where I was a nurse extern in the recovery room, thinking I wanted to be a nurse anesthetist. That went into working in recovery room, ICU. Then I took the oath of office as a commissioned officer in the Air Force Reserve and a flight nurse, and also got the honor of doing some critical care air transport missions, which was really cool. Then into the medical device market through ENT. So I've had the opportunity to see over 8,000 ENT cases and procedures in that time, as occasionally circulated into the OR as a circulating nurse, but more importantly as a vendor in the ENT world. Then I transitioned into sleep and then did some government contracting for appliance, small companies, small oral appliance companies. And I fell into this opportunity with GM Instruments. Now, GM Instruments is in Scotland. So I've been with them since the latter part of 2017. And it was at that point that I discovered that the ENT world was not measuring nasal function. Now that's important when it comes to breathing. But nasal function is very key. But more importantly, I discovered this as a mom. So I played the role as a commoner who had a son with an occasional snore, which I knew was not normal. At the time, I was working for a home sleep test company. So I went outside the guidelines and just did a little test to see, can I get 4 hours of data to see if he even had an AHI. He did. And I asked to look at his tonsils, 4+ tonsils. He would get to that threshold of ear infections, but not quite there for PE tubes or the pressure equalization tubes that you commonly hear in the market. So at the time, I called my favorite ENT, Gail Anderson, who I did a lot of cases with and had a lot of influence on my role here in the Washington, D.C. area in the ENT market. And I called her, I said, on her cell phone, I said, Dr. Gail, are you still doing coblation, which I love for many reasons, the technology. And I called her and said, are you doing coblation? Yes. Can I have an OR day next week? Sure. I'll see you in the office when? Friday, Thursday, we'll do a pre-op eval. And we did coblation on my son. That was in second grade, and he was 7. And I
Very
think what...
quickly, Karen.
Yeah.
What? Because from like a non-medical question, what is coagulation in like simple terms? I'm just I don't know it myself, so I don't know. I want to say the stupid question.
No. So well, I'll get to that question in a second. But what was interesting is that this was when he was 7 years old. And he had been to the dentist, but nobody really picked up on the dental issues, the teeth crowding. As little children, they should have, the teeth should look like little picket fences. There should be little gaps. Well, I was quite impressed because he had this beautiful smile and his teeth were together. But he also had chapped lips, didn't pick up on that. He had shadows under his eyes, so it looked like he had black eyes sometimes. I wasn't putting it all together. And so we did the coblation, which is a radio frequency type of procedure. And there's many ways to take out the tonsils. They'll do it by cautery, which is like a Bovie pencil, like heat. Then they can do it with what is called a Fisher knife and a loop, like they loop around, like lasso the tonsil and just cut it off with cold steel surgical trays, or coblation. So it's a radio frequency, has a little bit of saline at the bottom to kind of, calm down the temperature. It has low thermal energy spread, so it's not real damaging to the collagen in the tissues. And what's ironic is that I launched with them when I was with Gyrus ENT, now Olympus. I launched with them back in 2005. So it goes way back. And even with the balloon sinuplasty, which is a whole nother conversation. But what was interesting is that the snoring stopped. But this was a child who was told, he needs medicine. He can't focus. He can't sit still. Now, my experience goes back to a brief time in children's mental health back in 1995. At the same time, I was starting nurse practitioner school. So I knew enough to be dangerous, but not enough to be reassured. And I said, no to medications. I knew the side effects. I knew the problems. And I was like, no to medications. So fast forward to 5th grade, we started expansion. And he did a quad helix self-activating expansion. So I didn't have the turnkey. We didn't have any screws in the palate. It was just a slow self-activating expander. But what's interesting is that his dentition age was 3 years behind. So even though we started expansion at 10, his mouth was really 7. And then 3 years later, we started Invisalign. And he's got the most beautiful smile. Now, what's interesting is that he is at a baseball academy living in Virginia. I call it boarding school for baseball players. And he came home over spring break. I noticed his stats were going down. I noticed he wasn't hitting as well as he was before he left his sophomore year in high school. And I thought, something's not right here. I said, come here, kid, smile for me. And don't you know, Matt, the kid has a class 3 malocclusion. I about went bananas because that occlusion is a result of not wearing the Invisalign, which goes back to nasal function, and it's all interconnected. At the same time, he was complaining about his posture. So I did a little trick, and I tricked the trigeminal nerve. And when I did that, by the bite force on the molars, I was able to straighten his posture, and off he goes. We did do some chiropractic work to get him readjusted. But my point is that the nasal function, how we breathe, is so interconnected into what we do. And if we don't breathe well, we will never sleep well. We will have a nasal function disorder or a nasal function malfunction before we actually have a sleep disorder. This takes time. Nasal resistance is the culprit. It's the amount of pressure related to the amount of airflow that we can get into our nose for adequate breathing. Now, why is this important? Because 80% of our airflow and respiratory function comes through the nose. Then we look at upper airway resistance, which is very common. Now, upper airway resistance, we can't really see on a sleep study. We always wait for the AHI. And I'll tell you a funny story about that. But at the end of the day, we're waiting till someone can't breathe to help them breathe. And that makes me go bananas. But we have these flow limitations in the nose that create pressure changes in the back of the throat, and how those structures back here respond to pressure changes will affect our sleep. So when we look at upper airway resistance, we know that the nose is the culprit of over 50% of upper airway resistance. And of that 50%, 2/3 of resistance happens right here in the first about 1 inch of your nose.
Oh, really? Okay.
Yes. So no matter what you do, you cannot breath work your way out of nasal resistance. You cannot lose weight out of nasal resistance. And here's why. There's 3 components, and we have to look at 2 things here when we look at breathing and we look at nasal function. And it's anatomy and aerodynamics. Those two are so important. And a lot of practitioners don't consider those, which, that's where we can measure it, we can quantify it, we can actually see it in real time data while someone's actually breathing. So let's go back. When we look at anatomy and we look at this first 1 inch, there are 3 components that contribute to the aerodynamics in nasal function, how we breathe. The nasal valves, the nasal cavum, and I just had a brain freeze, and the nasal vestibule. So the nasal vestibule is this area. Then we have the nasal valves, and there's 2 sections to the nasal valve. There's the exterior and the interior nasal dilating sections. And then you have the nasal cavum, which is just a little bit behind there, just kind of a bigger area. But the nasal valve is so important, and here's why. 30% of people have some form of nasal valve compromise. What does that mean? When we breathe in air, it's supposed to go in the nose, up the olfactory cleft, and we need some resistance. Now, resistance is important, but too much is where we get into problems. So I equate nasal function in the breathing process. Nasal function to the airway is like the pH to our blood. We need a little bit of resistance, because if we don't have enough resistance, we become positive pressure breathers, and we're not frogs sitting on a lily pad. We're negative pressure breathers. We need the resistance to slow down the air for filtration, for humidification. And a lot of patients that have a lot of turbinate surgeries, especially that inferior turbinate, that's the highest point of resistance. And when it's not there, you feel like you're breathing, but you're not really breathing. And I see this a lot in my office, and when I work with doctors using the rhinomanometer, which we'll talk about. But we see this, and patients say, I can breathe. And I can look at them, and I created what's called a Maverick nasal exam, which it's a lot of information. We can talk about it another time. But I can, within 30 seconds to a minute, know exactly what is happening just by the structure of their face, their posture, and when they tilt their head back. So I look for the symmetry in the nostrils. If your nostrils are asymmetrical, that's where the aerodynamics comes into play. Now, when we talk aerodynamics, you've heard of Pascal's law, which is, the amount of volume that increases to the 4th power, and so on and so forth. That's gone. Sorry to disappoint anyone, but that's gone, because volume does not equate to function. And when we look at function, again, there's 2 structural components, mucosa and bone, that all play a role in this nasal function and how we breathe. So if you have dysfunction structurally, mechanically, or whatever the case may be, or with allergies, you will never be able to breathe well. And it all happens in this first 1 inch. Pretty cool, huh? But when I look at sleep studies, when I worked for an HST company, I was sitting at an in-service, and they were talking about the AHI. Now, remember, I'm a critical care nurse, so I'm like, thinking oxygen, carbon dioxide, how does this all filter out, and breathing and respiration rates. And I'm thinking, I'm airway trained. And so I'm sitting in the in-service, and they're talking about the AHI. And I raised my hand, and I said, AHI, apnea hypopnea index. This is the dumbest thing I ever heard of. And everyone turned around in the room and said, did she really say that? Yeah, I did say that. Because my feeling is, and what I learned first in nurse practitioner school was, why are we waiting until someone can't breathe to help them breathe? Now, nasal resistance is very slow. It's very insidious. It's very sneaky. It is a combination of time of this happening. It just doesn't happen overnight, and neither does sleep apnea. So we're trained for preventative care, which is not very common in the U.S., per se, because we are trained to treat diseases, give it a pill to the diagnosis and hope it works. And that's kind of the medical model that we have. And we need to change that thinking. So, in essence, can sleep apnea be prevented? And my thinking is yes, we can see functionally what's happening in the nose long before we get to sleep apnea. Make sense?
Yep. And first of all, just
I
note
know that was a lot of information.
I have a lot of questions for you, Karen, so watch
Yes.
out. For anyone watching, first of all, they can, if you have a question for Karen or even myself, you can put it into the comments on Instagram, YouTube, or LinkedIn, and we will try to answer that later in this session. Let's say, because you're obviously very high level on this, let's say somebody watching, normal person, they have a bit of a blocked nose, maybe they have a deviated septum, they may have some light sleep apnea. Right now, if that person goes to ENT person, normally what happens is they're given a nose spray or they're told to get septoplasty. If they go to sleep clinic, if they've got sleep apnea, they're just told to have CPAP. That's basically what people are told. So in basic terms, what else can people be doing to help with this nasal resistance?
Yeah. So I work a lot with athletes, specifically my son's team. And I had some serious mouth breathers in my office about almost 2 weeks ago. So here's how I approach things. I'm assertive. I don't like the word aggressive. I'm assertive in my care, but I'm very conservative. I like to look at lifestyle changes. Is there mold, dust, food allergies? Is there anything around that, environmental issues that you could change? Then I measure them with the rhinomanometry. Now, it's 4-phase rhinomanometry, and this allows us to see how much resistance is occurring while you are breathing in the awake state, sitting or lying down. So based on that, I can see what's going on in the nose. I can look at the breathing patterns. Are they consistent or are they just erratic? I can see tongue posture, which I've coined crazy tongue. So if it's a failed frenectomy or a tongue tie release and the tongue is not strong enough to stay in place, it will fall back in the throat. It will interrupt those pressures and increase resistance. So I look at what is happening, the breathing pattern, the amount of airflow coming into the nose. It's going to equate to the amount of resistance. And once I see where somebody is, then I can kind of tell, what's going to be best for them. So then I test with spray. Now, in flying status, we always had a standing order for Afrin for nasal congestion. But I'm not an Afrin advocate, because the other thing you have to consider is what is in your medicine cabinet. What medications are you taking that have the side effect of nasal obstruction? Antihypertensives, NSAIDs like Advil, nonsteroidal anti-inflammatories, hormone drugs. And that's things we have to look at as well. So what does your body tell you? Our body talks us through symptoms. So I use Xclear. That's one of my favorites, the xylitol. Simple sugar product, homeopathic. And I spray the nose and I wait 10 minutes to see if there's a difference when I remeasure somebody with the rhinomanometry. Then, this is just my protocol. Then I see if there's a nasal valve issue. Now remember, 30% of the people will have a nasal valve issue, however so slight, but that will change the way that air comes into the nose and circumvents that nasal valve to get warmed and filtered, right? So I use intake. I love intake because there are 6 different sizes. And I can pretty much gauge how much pressure I want to pull on the lateral nasal walls. That's another component. And there's a sweet spot, again, with nasal resistance. So I can use the intake, a small one, like an S2 right here, and have just a little bit of a pull because it's based on... Yeah.
Sorry, Karen. So intake, is that a type of like nose tape? Or
it's a nasal dilator. Yeah. It's a nasal dilator.
Okay.
Yeah. If you go to my Instagram page, it's _ the nose. and you go into my link tree, then you can see like how to go through the whole ordering process as well.
Okay.
But I found really good results. But again, there has to be the right size, the amount of pressure that you pull on the lateral nasal walls, because if it's too much, it can have a reverse effect, right? And if that works, nasal spray, Xclear, xylitol, intake, external dilator. If you're feeling, now what you feel and what's actually happening is going to be different, and that's the Weber-Feichner law. We have the psychological feeling of breathing, but how we respond to the stimuli of actually breathing can be different, if that makes any sense. But I talk about that in the book. And that's kind of our new thing that we look at. And Dr. Klaus Vogt, the father of rhinomanometry, coined functional rhinology. So it's that functional nose. And we created a new medical term, rhinopathia. Rhinopathia, nose disease. And we can look at the characteristics of a nose. We can look at the mechanical aspects of the nose and how it's working. But we also can look at the genotype. There are 4 genes that influence our nose. And again, how we're going to breathe. So this gets really, really deep. But if I find no resolve from a spray and a dilator, and I see that there's no allergy or mucosal component. Remember that inferior turbinate is your highest point of resistance when we breathe in, right? If I don't see any change in mucosal issues, then I know it's a structural problem. And that's where I go into an ENT. But the problem is that all of my ENTs are not on board. They want to go, beeline to surgery. But I think there's other ways to address it, if that's helpful. So again, I'm conservative. I'm like, what is your environment? Have you changed even your bed pillows? Have you changed your bed pillows? What's your diet look like? Drinking, things like that. Are there any lifestyle changes you can make? Does a nasal spray help? Does a nasal spray and external nasal dilator work? How are you seeing progress? And like I said, the one thing I like about the intake is that you can go through all the different sizes. Like their starter pack has 4 different sizes. So you can really see what's going to work best for you. But again, more dilation and more pull here does not always equate to better breathing. And that's what I'm studying now. I'm looking to see how does the pull on the lateral nasal walls to open up the airway, how is that affected? Then there's also myofunctional therapy. Then there's the dental world with expansion. So there's so many different options. It just depends, where are you on that severity of nasal resistance that is affecting your breathing. And I think the one thing that's really important to remember is that nasal performance on inspiration is 1.2 times higher than expiration. So when we breathe, our nose has to work 1.2 times higher than we do when we breathe out. So there's all these little moving pieces, parts, and puzzles. And that's book number 3 that I'm working on. But there's all these different moving pieces and parts. And I think that when people say, oh, the child isn't sleeping, isn't breathing, it's ADHD, that's the root cause. No, we cannot go, always to functional breathing as a root cause, because like in ADHD, is it a dopamine change, level and changes that are affecting it? Is it the hippocampus and amygdala that are playing a role? So we have to look at the whole picture holistically and not get so siloed into one aspect or issue. Is that helpful?
Very. So it sounds like for a lot of people who have nasal issues, which I think is a lot of people, I don't know what the statistics are, you can maybe help me on that, but I think a lot of people have issues in terms of breathing, their nose gets stuck a lot, they end up mouth breathing, and just knowing there's maybe other ways out there to deal with that. Because I've had septoplasty surgery and it wasn't a bucket of fun. It was pretty brutal. So it's kind of, I think if there's a way to avoid that, that's a massive win-win for a lot of people. And I guess my next question, and I think you have a few comments on that, but what is the benefit of nasal breathing overall? Are there a few key points that people should really take away on that?
Yeah, so as far as nasal breathing, and I call it nasal function because we have to have function in order to breathe. And nasal function is so important for, of course, oxygenation, nitric oxide production, filtration, humidification before that air gets to the lungs. But one thing I want to focus on, and I see this a lot on social media, is that everybody's on the bandwagon about nasal rinsing and nasal lavage. Well, I'm not very keen on it outside the presence of disease or mucus presence, and here's why. We have normal bacteria in our nose and our nasal mucosa that we need. And if you keep rinsing that every single day, like with the lavage or the neti pot, you're basically rinsing out your defense. So when people ask me about nasal rinsing, I like it in the presence of disease. Because remember, when we look at nasal congestion, another aspect of function, is it a pathology? Is it a disease happening? Or is it a structure happening? And to your point, I mean, 70 to 80% of the people have some form of a deviation. And when you go back to birth, 20% of the etiologies in breathing disorders in babies are due to a vaginal delivery. Because remember, we only see 30% of our nose. It's the most projectile part of our body during birth, right? So I also ask people, were you a C-section or a vaginal birth? Because if you were a vaginal birth, you could be in that sector that had that trauma right to your nose coming out of the birth canal. And that's nature. But it all plays a role in our development over time. Now, what's really cool, and hats off to the EU. The EU is about 40 years ahead of the United States. Sorry, US doctors, but that's the truth. And they do a lot of rhinomanometry. They look at the pressure-flow relationship of breathing. And Dr. Wagarborski, he produced a paper in 2022 stating that we can do rhinomanometry, we can do nasal function testing in children with reliability, predictability, and repeatability as young as 3. Now, a lot of people say fixed by 6. So I created a campaign, we can see at 3. If we can see the aerodynamic and the structural changes in nasal breathing in children as young as 3, think of how much we could save in the healthcare dollars. Because to your point, sinus surgery, and this was part of my research for my doctoral defense in health policy to try to change it. When you look at sinus surgery, there's a 12% revision rate within 1 year, meaning people that have sinus surgery, 12% of those people will have to have another surgery to correct the problem from the first surgery. So there's a lot of anatomical things that can happen here.
I have another question for her. So, and you speak at very high level.
We could talk for 3 hours.
Maybe it's round 2 and round 3, Karen. But
yes, that's a good idea.
You touched on something that I was going to ask you a question, which is basically why are so many people breathing badly for their noses in the first place? Like, if we're meant to be breathing for our noses, why is it that our bodies aren't? And you mentioned one thing which I never heard of, which is basically like how you're born. Like if you're born in a normal manner, then I guess it can be quite traumatic, and your nose gets bumped or things happen during the birth, which then affects your nose the rest of your life. But are there other factors in terms of our lifestyle, childhood, other things that which are making us breathe through our mouths when we shouldn't be?
Yeah, and this is just my opinion, but I think it is lifestyle. I think it, if you go back to the earlier ages and our ancestors, you could see that they always had these nice, pretty square jaws. I think a lot of it has to do with diet, the processed foods, the junk that we're eating. I think also there are some structural issues as well. Remember, if you can't nasal breathe, everything starts to become elongated, right? And we have to understand that nasal airflow and function precede formation. What does that mean? Think of the air as like water. They both will follow the path of least resistance so we can survive, right? So we go into this compensation mode. Then the autonomic nervous system kicks in. We're in fight or flight. We're always in this high stress volume. We also have high stress lifestyles as well. But air will follow the path of least resistance. And that flow will create the formation of our face. So I think that we are walking around with functional problems that we can't see. Remember, nasal resistance is slow, insidious, and it's cumulative over time. And that accumulation of not being able to breathe appropriately just builds up and builds up. Now, another alternative or another factor could be concussions. When in trauma, there's a concept that's called coup contra coup. Coup is when the head goes forward. Contra coup is when the head then comes back after impact. And the brain follows. And as part of that, the brain stem is jiggled around. I know, nice medical term, but it's shaken a bit. That's our respiratory center. So when I work with veterans with PTSD that have blast injuries, shockwave injuries, or actual concussions, that also plays a role. Now, in the US, we have about 3.1 million concussions, and of those, 30% are kids. So when I work with people, I ask them, again, their environment, concussion history. Has anyone ever told you you have ADHD-like behavior? How were you born? Vaginally or C-section? Because when we go back as far as birth, that's where it all starts. Even in utero, there's some theory to believe it even starts in utero. And that's, again, through environmental factors. So it's very multifaceted. There's structure, there's tongue function, there's the facial formation, concussion history. It's very complex. That's why I call the nose the most reactive organ that we have in our body. It's very reactive. It senses danger. It senses pleasure. It triggers memories. And what's interesting, even memories, we can trigger memories of perfume and cologne as far back as 4 and 8 years old. So it's really awesome, and then we have to look at the messaging in the brain as well. So it's very complex. We could go down a rabbit hole for 4 hours, but it's multifactorial, and I think everybody will have an opinion on that. But I think a lot of it has to do with environment, the processed foods, nursing. Are you able to nurse as a child? That plays a role in it.
And just to touch upon something you mentioned there, if someone has ADHD, it's been diagnosed with it, or this they think they do, is it recommended, would you say, that they should also get their nose checked?
Absolutely. Get your nasal function and a sleep study done. When I worked in children's mental health, my profile of patients were 3 to 13 years old. And I can tell you as a fact, in my caseload, not one child had a sleep study done. Not one. And rhinomanometry was just coming out, so we couldn't really do nasal function testing. But breathing and sleep, maybe sleep patterns, but actual snoring, bedwetting, all of the symptomatology for pediatric sleep apnea was never asked. And I know that because I did the intake on my patients that were coming in. And the tide has turned, and I'm happy it has almost, 30 years later. But it's really important. So, if somebody says you have ADHD-like behaviors, do what I did and look at the structure, the tonsils, the breathing before you do any medication. Because, like in the U.S., if you look at the number of children ages 5 to 17, there's like 5.9 million children with a diagnosis of ADHD. And of that, 67% are on medication. Well, guess what? Not one mental health disorder is without a sleep problem. Think about that. Not one mental health disorder is without a sleep problem, whether it's the pathology of the diagnosis or the medication. So if we're going to give a child a stimulant for ADHD, which I had to try it for my son, we did Foculent, and we did Metadate. And those are stimulants. So what's that do? It revs up the system. So it's kind of it's a double-edged sword. But absolutely, if someone says ADHD symptoms, get a sleep study, get nasal function testing done, look at that nose, look at your breathing, because that can be the precursor to what's actually happening. And also, when we look at nasal resistance, there's a certain level of things that happen in our physiology. Like we have a normal nasal resistance that we see on rhinomanometry. We go a little bit higher in resistance. Now we're a mouth breather. Just like a plane, we need an emergency exit, and the mouth it is. We go a little bit higher. Now anxiety is kicking in. So we can see what's happening on the tracings during a test. It's quite fascinating. And that's a whole other conversation. But we can be very, very proactive.
I can speak partly from my own experience. I've been on a bit of a nasal journey the last 3 years. I really put a lot of time into improving how I breathe from my nose. I had septoplasty surgery, and my sleep scores are considerably better.
Fabulous.
If you look at my transformations on LinkedIn, even I look quite a lot different to what I looked like 3 years ago, and I think there's many factors behind that. But I am curious, like you mentioned, there's a lot of facts in terms of how nasal structure can impact teeth, jawline, face shape. Can that also affect how people look later in life if they correct? Like if someone's 40 and they've had bad nasal breathing for most of their life, can that still impact their facial structure? Or is this just purely childhood, teenagehood? Basically?
Yeah, no, it actually happened to my dad. So my dad, I looked at him, I said, "Daddy, your nose looks funny." And I looked at a picture from 3 years ago, and I looked at him now, and he has an anterior deviation, but he's also a mouth breather. So as you mouth breathe, the face gets longer, and everything just it's like a little pup tent. It just starts collapsing. And you can see it in the bite. You can even see it in the deviation of the nose. I mean, you do get facial changes over time, slowly. That is true. And if you look at Dr. Harvold in his study back in 1982, he plugged up the noses of rhesus monkeys for a certain amount of time. And because they were mouth breathers, the face became longer and longer and longer. They had that maxillary deficiency, and the vertical growth height was changed. But when he unblocked the nose, then their facial structure went back to normal. Pretty cool.
Wow.
And you can see the picture is this long face, and then it just goes back to where it is. Yeah. Yeah.
Interesting.
So the short answer is yes, you'll see changes. Mm-hmm.
I mean, I'm guessing there'll be a lot more science come out on this in future years, but it's if that's true for people as well, then that would be quite a staggering factor, that literally the way they look is in part, if not quite significantly, impacted by their nose. Yeah. And I think there's a lot of people that will scare people, but maybe in a good way, in terms of I think this whole area here is a lot more important than people give it credit for, and it needs more attention. And it's exactly why I wanted to speak to you about this, because I don't think it's spoken about enough, and I think the benefits are insane.
Yeah, and I'm probably going to upset the sleep world, but Matt, this is my opinion, is that everything on social media, I mean, it is, and I wrote an op-ed to the Wall Street Journal, and I know it was read because the editor came back and said, "Thank you for your submission, but not today." And I think I might post it on LinkedIn. But when you look at social media and you look at medicine, everything is sleep, 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 and more sleep. Sleep apps, sleep testing, sleep devices. Everything is about sleep. But we have to breathe well in order to sleep well. We're looking at 1/3 of our day, but we're forgetting about 2/3 of the day. We don't walk around with CPAP. We don't walk around with oxygen tanks during the day, right? So I'm trying to transition that thinking that let's look at the daytime and how we're breathing and what's going on so that it can enhance our sleep. I think we've just kind of jumped forward and just, disregarded the precursor, and the one aspect, which is the nasal dysfunction and the nasal breathing, and how that flow and how those pressure changes are affecting the back of our throat, how we sleep, even our structure. Yeah. And that's why I got my book. I got the book here. It's going through several edits. We're almost there, but it's called Breathe Through Your Nose, Don't Pay Through It. How the healthcare industry looks at healthcare or nasal function and how we breathe. And I broke it down into 4 parts because I wanted to examine how each aspect of the healthcare industry views nasal function and breathing. So I talk about the insurance companies, the research I did on reimbursement here in the United States, preventative motions, even just the basic anatomy and physiology of nasal function and how it plays a role in our health. So excited about that, and more books to come. And children's books are coming out. So a lot. Yeah. So I did a children's version of Breathe Through Your Nose, Don't Pay Through It. It should be out hopefully in June. It's called My Little Nose, Where the Air Goes. And I did one for girls and one for boys. So there's one that has all girl pictures and one that has all boy pictures. And it just talks about nasal breathing and what it does and how cool it is to nasal breathe to get that message out earlier. Mm-hmm.
Excellent. That is absolutely fantastic. So I'm going to very quickly check if there are any messages from people. But I have one question to leave you on from my side, which is, what do you think of mouth tape?
Oh boy, do we have another hour. So, in my research, doing rhinomanometry, we have to remember that the nose is sympathetically driven. And how we decongest is by withdrawing the sympathetic charge to allow the parasympathetic charge to become dominant. Now, when we look at the trigeminal nerve, which is the 5th cranial nerve, the largest cranial nerve that we have. It has V1, which is ophthalmic, V2, which is in the nose, and V3, which is in the mandible. And V1 and V2 are sensory, and V3 is sensory and motor, which is the mandible and here. V2 is in the upper lip, V3 is in the lower lip. What I'm finding is that when you do a full mouth tape, it will stimulate the afferent or the feedback in the neural pathway from the lips to the nose, and it increases resistance. So when I have to jump from a bed to protect the airway in a matter of seconds, from the foot of the bed to the head of the bed in recovery to an anesthetized patient, I have to protect that airway. I think about people in mouth taping, I'm a hard no. Now, there is an exception. Full mouth taping, no, because the nerves in the lips are being stimulated to produce that feedback loop to the nose and increase the resistance. And I saw this with rhinomanometry, so it's not an assumption. It actually happened. However, if you have to mouth tape, and there are situations, for example, someone who's trying to retrain nasal breathing, they may have that lip incompetency or the jaw issue, and they might have to do a little vertical piece. I'm okay with. But you have to be able to open your mouth if you have oral contents, if you get sick, and if you have to open your mouth at all to breathe. Because remember, with sleep apnea comes like gastroesophageal reflex, laryngeal reflexes. You have those oral contents that can come up in the mouth and they have nowhere to go. And I've seen CPAP users do mouth taping. And I get pictures from providers like, what is happening? I'm like, yikes. They'll mouth tape with a CPAP machine, and again, they have no expiratory route, and they end up with cheek puffing. And I also saw it on a TikTok video where they taped a guy's mouth, and he started puffing his cheeks. That's not safe at all, at all. Remember, we have to have an airway route and an oral route. They can't be compromised at all. So, full mouth taping, I'm a hard no because of the neural pathway and the sensitivity and what's happening in the nose. A vertical piece, I'm okay with, but I call it a straw sip test that doesn't, it doesn't negate any kind of other testing or exam. But a straw sip test is, can you get a straw in your mouth if you need a drink at night? or if you have oral contents, do you have that emergency exit route? Is it available? So that's where I stand on that. Just my 2 cents.
Very interesting, very useful. So I think we can
And I do have I have a paper coming out on that. I will have a paper.
Okay.
Yeah.
I'm very curious to see what new studies come out in terms of mouth taping in particular.
I mean, the studies out there like, oh yeah, it can decrease the AHI. But remember, nasal resistance influences the AHI. AHI does not influence nasal resistance. And that's important to remember. Yeah.
Forgive me. I think I need some water. I've maybe not been breathing well enough during this. So I think I didn't see any other comments. So I think we probably need a round 2 or 3 later down the line. But I think there's some fantastic information there. So I really, really appreciate you taking the time to speak to me.
Oh, yes.
Anyone who's live here, and I think a lot of people will be watching this as a recording later.
Yeah.
So if anyone,
my absolute pleasure.
Absolutely. If anyone who watches this later, you can still write in the comments. One of us will see it, and I can maybe pass it on to Karen. And where can people find you again? Just for the book, also for all this useful information.
Yeah, so I am on Instagram as @_the nose knows. So it's THENOSEKNOWS. So the nose knows. Also on LinkedIn, and then I have a website where I can get messaging, which is FACT FACTHCG.com. So it's facthcg.com is my website. I've got a personal one coming out, and once I get everything up and running, I will give you a QR code for a discount on the book for your viewers.
Oh, excellent. So looking forward to that. I'm going to end the stream now. So thanks so much for anyone watching, and we'll be more of this.